Okay, good. So last time we were talking about volume loading and what the effect of volume loading would be on the remodeling. And the idea is today to talk a little bit more about pressure loading, so a bit the counterpart when it comes to loading changes. So what you always have to keep in mind is, like, when you look at or when you want to interpret the heart of a certain patient, is that you have to keep in mind that, as I said in the beginning, that the heart will remodel in order to cope with changes in circumstances. So it will try to adapt in such a way that it would be able to generate the cardiac output that is needed in order for the body to function. So, and what you will see is this imbalance can be different ways. We said that before. So what you have is that a certain heart with a certain geometry and a certain size is optimized to work under certain conditions. If these conditions are changing, whether that is due to some abnormalities or whether that is due to, for example, doing more exercise or even growing older. So what will happen is that this optimization, this balance between what the myocardium can perform and what is needed, that can change, and that will induce remodeling. So for example, if due to aging or more and more hypertension or more, for example, aortic stenosis, the pressure required in order to do the output will increase, what you will have is that then, of course, that the internal pressure and thus the wall stresses and the stresses that the myocytes feel are changing. That means that this becomes an imbalance where either the heart will acutely fail if there's no way to cope with it, or if there's enough time, it can remodel in order to restore this balance. Now, similarly, this balance can also be changed when there's something wrong with the myocardium. And so, as we said before, when you have, for example, ischemia or something like that, or you have a genetic condition where you have an abnormality in the tissue, then even with normal loading, there could be an imbalance. And you will start to get a process of induced remodeling, which can be associated with damage or not, in order to cope with this. So this is what you always have to try to keep in mind. The heart as a whole will try to be in balance. But of course, the stimulating forces for this is what the individual cells feel. So we have to try to understand how individual cells will be influenced, how that will be incorporated within the whole myocardial wall, and thus within the whole functioning of the heart. And as I said before, one of the important triggers there, and one of the important things is how the pressure is being translated into what the myocytes feel. So what is the wall stress? And then for simplification, you can say that you can use the law of Laplace, which is in principle for a sphere, but it's roughly true for the heart also, which means that the wall stress, so roughly what the myocytes feel, is proportional to the pressure. Right? So of course, when you have an increase in pressure, you will get an increase in wall stress. And very, very importantly, is related to the geometry, namely the radius of curvature. So locally, the more curved the myocardium will be, the lower the wall stress for a certain pressure. The more flat the myocardium is, the higher the wall stress for a certain pressure. And additionally, it's inversely proportional to the wall thickness. So a thicker wall will have, on average, a lower wall stress compared to a thin wall. Now, these are simplifications, but it helps us to understand quite a lot of things already, namely looking at shapes and overall how hearts are remodeling in order to cope to different conditions. And we know, for example, that pressure-loaded hearts tend to become thick-walled with a very, very small cavity. So in order to increase the wall thickness to reduce the wall stress, and of course also kind of decrease the radius of curvature in order to decrease the wall stress also. While what we see is that you have these very, very baggy hearts, for example, they are not able to withstand any pressures. There's really bad for pressure loading. So a dilated cardiomyopathy, for example, if then additionally they start to get hypertension, these hearts tend to fail very, very quickly. Now, of course, what we said before also, when you think about one of the previous classes when I was talking about volume loading, of course, I mean, getting a smaller cavity is, of course, worse for volume output, because, of course, you cannot eject more, even if you're maximal strain, so that you collapse your cavity the whole time. Of course, the total amount of volume in there, which is then the maximum stroke volume, is of course small. And that means that these hearts, which are so small, have to work almost by definition at higher heart rates in order to be able to perform the output. But if you then look at the clinical part, for example, what you tend to have is that these small hypertensive hearts, what they do is they get beta blockade. So they are artificially reducing the heart rate. And this can at some point, of course, become a problem for the cardiac output. So all these things you have to always keep in mind at the same time. Now, also related to this, and we mentioned that before, is also then looking at this shape of the heart. I mean, what we said before is like a normal ventricle, a normal left ventricle, and right ventricle, even more, is actually ellipsoid. It's relatively elongated. And the reason for this elongation is that you can actually prove that the stroke work, so the amount of volume that can be ejected by a more elongated heart is actually more than a spherical heart. So the more elongated the heart, the better for volume output. But of course, the more elongated, the flatter the walls, the higher the wall stresses. So a very spherical heart is very good to work at high pressures because wall stress are relatively low, but at the cost of volume efficiency. The other way around, a very elongated heart is very volume efficient, but at the cost of higher wall stress when pressure increases. And that gives us that a normal ventricle, left ventricle, has a kind of an ellipsoid shape. And actually, when you look at the right ventricle, mostly the right ventricle is even more elongated. Of course, it has this kind of crescent moon shape because it's kind of attached to the left ventricle, but in total, it optimizes better this volume versus pressure because it works at lower pressure. Now, what you see now also is that, of course, I mean, this is for the overall heart, and especially for the mid and basal part, which is actually the predominant part. What we see in the apex, it could be that, for example, the apex is actually a little bit more efficient when it's more spherical, because this very, very kind of pointed apex is a little bit less efficient. So we see there also is that it's not only the overall shape, but even how the shape of the apex is changing is actually quite relevant. And you see that, for example, when you look at kind of right ventricles, which start to fail or which are volume overloaded, for example, tetralogy of Fallot versus like pulmonary hypertension and things like that, the shape of the apex can become important because again, it shows us something about the combination of pressure loading together with volume efficiency. Now, if we try to understand what the changes are in deformation or how we can interpret changes in deformation, when we have loading, we always have to go back to this kind of Hooke's law, like the basic law that relates kind of deformation with kind of forces. And so Hooke's law says that the force, which means the total, the conglomerate of all the forces, is related to the deformation through the elasticity. So deformation will change if forces are changing and will change when elasticity is changing. Now, the forces, as we said before, consists of several, where the contractile force, of course, is one big part, but contractile force is what is being developed within the myocardium. But when we look at a piece of myocardium, contractile force is not the only force, because as we said before, so the pressure loading is another force, is a very important force, always keeping in mind that when we look at a certain segment and look at the contractility there, the pressure is actually developed by the whole of the myocardium. And especially when we look regionally and when we look at diseases where there are regional changes, then there can be a difference between this contractility and the loading from the pressure, so the force from the pressure. The other thing is, of course, the segment interaction, and of course, also the pressure loads the segment, loads the myocyte through its geometry, as I said before. So depending on the shape of the endocardium, you will see that the pressure, not only the amplitude is important, but also the shape, because that tells you how it translates to the force that the myocytes are feeling. So if you then look at kind of acute loading, what we will see is that, of course, in this balance, if we increase the pressure, so for example, you do a constriction of the aorta, or you somehow constrict the aortic valve, or your peripheral, you get, for example, peripheral vasoconstriction. Could be when you go out in the cold, when you go to the toilet or something like that. So what happens then acutely is, of course, that your deformation will go down. If the force of the loading goes up, the contractility remains the same, the balance changes, and of course the deformation goes down. And that's the thing that you see, is that with a certain afterload, when we would look at a constant contractility, our rate of deformation and amount of deformation will go down. In case nothing changes, we come back to that, how the heart can adapt in these cases. And then in order to compensate it, so if you want to maintain the amount of deformation, because in the end, the amount of deformation together with the shape of the heart is what determines the stroke volume, and that's what you need to maintain, then of course you should have to increase your contractility overall in order to compensate for that. And so this is kind of the theoretical part, and you really see that this would happen also in some experimental settings. Now, one of the things which is also important to note is that, as we said before, the heart is not homogeneous, and different segments can kind of show different remodeling or different loading or different conditions. First of all, the heart is not uniform because it's not a sphere, and we'll come back to that later on. And then secondly, the heart is not uniform because when we look segmentally, first of all, of course, the coronary circulation segmentally is different. And as we discussed before, it's like when we look at the coronary arteries, there's a very sharp demarcation between different regions of perfusion territories. So that makes that the local contractility will be different. But of course, also many disease processes, and especially when we think about genetic diseases, but also some others like deposition diseases and things like that, they could have local variability. So that means that we really have to look segmentally in order to understand the deformation that we would measure there locally. And if we look at this segment and we want to look at the deformation, so we look at this kind of formula or this kind of balance from the Hooke's law, which says so the contractile force is important. And also one of the things we said before is the contractile force. It's really important to look at the timing of the contractile force in the cardiac cycle, because contractile force development starts when you have electrical activation, and then it rapidly increases. But what you will see is that about by 1/3 of the ejection phase, your force development itself is going down already. And in a normal heart, a lot of the ejection, so there is still ejection, there's still high pressure, is because of inertia from the kind of the initial motion or kind of the blood. And also looking at the contractile material and how it's built up. So what we said before, so you have actin. What happens is that the cross bridges, which are kind of bound in order to do the force development and to do the deformation, they have to be broken down later on in order to make sure that you're elastic for the next filling phase. So both the amplitude of the contractile force is important, but also the timing is very important. Then, of course, we have the loading force. And as we said, the pressure is high during the ejection phase and suddenly rises in the isotonic contraction and suddenly falls down in the isotonic relaxation phase. And we have to look what happens in the neighboring segments, of course, in order to see whether there's some interaction. And then we have to look at the elasticity, at the tissue, whether there are tissue changes. And only when we combine this can we understand what's happening locally. Now, when we look at what's happening with loading, for example, acute loading. So here's an example of an acute constriction of the aorta in an animal model. Sorry. So this is a segmentation. This is actually from 3D ultrasound. So this is a left ventricle, the endocardium. What you see there is that, of course, the lateral wall follows the curve of the outside of the heart. But of course, the septum, since it's shared by the right and the left ventricle, especially in the mid part, is very flat. So in the more basal part, where we also go towards the more fibrous septum, and we go there also like towards the outflow tract of the right ventricle. It's a little bit more curved, but especially base mid is very, very flat. That's the flattest area. Now, if we do an acute constriction, what actually happens, and this is also logical, right? This is also what happens when you have a balloon. When a balloon has no air inside, so the pressure is the same as the outside, it has no shape. But as soon as you put air in there, as soon as you increase the pressure with regard to the outside, it becomes spherical. And this is also what's happening within the ventricle. If you blow it up in brackets, so you increase the pressure, what happens is that it tends to try to become as spherical as possible, because of course, the more spherical it is, the lower the wall stress would be because of this law of Laplace. So what you try to do is the flat areas, you try to make them more rounded, because that means that the influence of the pressure would be lower. Now, remark already when we look at this kind of geometry, what you see is that this lateral wall is actually not changing much in shape. But this is, of course, because we have to keep in mind that the ventricle is embedded, as we said before, in the whole heart, and around the heart, we have the pericardium. So this is an experiment that was done with closed pericardium. So, of course, when we have a closed pericardium, if we increase it, the lateral wall, which touches the pericardium, is not able to change shape unless the overall shape of the heart would be changing. But as we said before, that is actually very rarely happening, because the pericardium is so stiff in some ways. So the only thing that can change shape is then the septal wall, and the septal wall will bulge towards the right ventricle. So it will kind of infiltrate in some ways or intrude a little bit inside the right ventricle, at least as long as the right ventricular pressure is not so high that it prevents this. We see, for example, when you have pulmonary hypertension, what we see is that the septum even flattens more, because it's always the balance between the left and the right pressure which determines the shape of the septum. Now, what are the consequences of this? So first of all, you can already theoretically see that if you become more spherical, your wall stress goes down. So that's a good thing in some ways, but you can actually see that this also has influence on deformation. So if you would measure the deformation, what you will see is that at baseline in a normal heart, you see that the strain is very homogeneous. In a normal heart, strain is the same almost in every segment, whether it's septal, lateral, base, apex, because this is by the myocytes, of course, and the myocytes want to do a certain amount of strain because that is what they're optimized for. If we do this acute pressure loading, what happens is that we see that in the lateral wall, you see an acute decrease of the deformation, and we see also there's no shape change. So if there's no shape change, what you will see is that actually the deformation decreases. This is what we said before. You change this balance between contractility and loading in such a way that the loading becomes higher than the contractility, which means that your deformation has to go down. However, what we see in the septum is that actually deformation can be maintained, and that's actually because you change the shape of the septum. So although you increase the pressure, you can compensate that increase in wall stress partially, at least by changing the shape. So the shape change makes that the influence of this pressure increase is actually being kind of diminished, or being flattened. So you see that this is like an acute way to adapt to sudden pressure load. And so if you have a normally shaped heart, the fact that you can change the shape of your heart actually makes that you can still function under changing conditions. And of course, we know that blood pressure is changing throughout the day, can change acutely. As we said before, if you go into the cold or something else, the heart needs to have adaptive mechanisms in order to cope with this, to keep the output, and this is one of them. Of course, you can now already imagine that if for whatever reason you already have a more spherical heart, of course, you cannot become more spherical with pressure loading, and you don't have this compensation mechanism anymore. So we'll come back to that later, to some of the conditions where that would be the case. So one of the things that you can also see is that, of course, depending on the geometry, that will be different. So your stroke volumes and your ejection fraction will be different. That's what we said before. So you will see that actually, even although you can maintain your deformation with becoming a bit more spherical. Of course, the more spherical you become, actually the less deformation or the less stroke volume or ejection fraction you can create with the same amount of deformation. So even if the deformation is maintained, it becomes a less efficient heart, but at least it doesn't acutely fail. Here is an example of this is now a right ventricle with chronic thromboembolic pulmonary hypertension. So you have severely increased pressures in the right ventricle, and you see immediately that this right ventricle becomes bigger, more spherical, and you see even that the septum is flattening. And we will discuss it at another time, and now at the cost of the left ventricle, because when the septum changes, of course, it always has an influence on both ventricles. That's what we have to keep in mind. And here you see what happens is, of course, after therapy, as soon as you decrease the pressures again, you see that it normalizes in shape, and that the left ventricle is also getting a normal shape again. So you see, when you see this kind of shape changes, you know something is wrong. So it works in both ways. So in the sense that you can predict what would happen with the pressure loading and how this would influence how the heart deals with it. But on the other hand, if you see a more spherical ventricle, for example, you know this has to do somehow with this pressure loading. So if you see a heart, like if you see just this image, even without knowing anything about this ventricle, what you know is that there's a problem with loading with regard to the force development that is available in the contractility, because otherwise the shape wouldn't become like this. Of course, this can be chronic remodeling, this can be acute remodeling. That's a thing that you have to then look more in detail, but you know that at some point pressure played a big role in this. So what type of remodeling is then taking place? So what's happening is, of course, when we have increased pressure loading, what you will see is that you get an increase in the systolic kind of wall stress. So what happens is your pressure increases. Even if you have a little bit of shape change, what still is the case is that the wall stress, when we look at the individual myocytes, will increase. And if myocytes are working for a certain amount of time under conditions of higher wall stress, what happens is that they release growth factors in order to try to remodeling. And the remodeling that takes place is that you get more contractile material in parallel within your myocytes, which means that your myocytes will thicken. So you get hypertrophy of your myocytes. And of course, you get hypertrophy of the whole wall. Your whole wall will thicken. And this thickening of the wall that you see in hypertrophy is actually a sign of increased contractility, because you know you have more contractile material. All hypertrophic cells have, by definition, more contractile material, at least in the compensatory state, let's say it that way. What you will have is, it could be that you have some genetic abnormalities where you have an increased size, but in principle, if you have bigger myocytes, that means that you have more contractile material per myocyte, and that at some point there was something going on that triggered this, because that goes further than just only the development, because you really get towards this. Are you still seeing my screen?
Yes.
Yes.
Okay, sorry. Because yes. Okay, sorry for that. So you get this remodeling, you get this hypertrophy, but on the other hand, of course, this is something that happens at the myocyte level. So these are individual myocytes. If the ventricle would be a sphere and the wall stresses would be the same everywhere, then you will get hypertrophy everywhere. But because of the fact that, of course, the ventricle is not, that means that some myocytes could have higher wall stresses than others, which would trigger the hypertrophy response earlier or later. And this is actually what will be happening in a normal heart, and I'll come back to that in a second. Now, another thing which is actually also interesting is when you look at how does this then contribute later on to the kind of decrease in wall stress, and here is some examples. This is, of course, as we said before, what happens is if you get hypertrophy, what happens is you have an increase in contractile force development. So that already balances your loading, so your increased loading, so increased pressure, you can compensate with increased force development. And then secondary is, of course, when you have a thickening of the wall, so when you have hypertrophy, you decrease the wall stress also because of the law of Laplace. And so you see here, for example, here are some experiments of some kind of relatively old experiments of chronic loading. So what you see here is, so you see the pressure. If you increase your pressure, what you will see is that actually the wall stress actually remains the same. And that is because what you see here, because of the fact that you have an increased wall thickening, and because of this increased wall thickening together with an increased force development, what happens is that the resulting wall stress, of course, maintains within normal ranges. So this is nice physiological remodeling, as you can see. Now, some of the things that you already start to see is that you see that there's also a change in timing, and I'll come back to that later on. For example, you see that there's a change in the dynamics, the temporal dynamics of the pressure and of the stress, which actually becomes important. Now, mainly also one other thing which is important is like when we look at the wall stress and we look at when the highest wall stress is actually occurring within the cardiac cycle, then this is not at the end of systole, because what happens is, of course, during the ejection, what happens is your cavity becomes smaller. And of course, the smaller your cavity, the smaller your radius of curvature. So that means, of course, that intrinsically you decrease your wall stress. So even if the pressure might peak, in this case, by the end of the ejection, what you see is that the wall stress is actually peaking in the beginning, just after the isovolumic contraction, sometimes even within the isovolumic contraction, because then you have the biggest kind of size with of course, the flattest areas. So here again, also thinking about what is the influence of the loading and when is this occurring, that has to do a lot more with the size of the heart rather than with only the dynamics of the pressure. So you always have to keep these two in mind when you try to understand this. Okay, so coming back to the fact that I said before is that the heart is not a sphere, or the ventricles are not a sphere, but they have a certain geometry. That means that there's regional differences. Now, when we look at a normal left ventricle, what we said before, this is like ellipsoid shape. And what you have is that actually the apex clearly has the smallest radius of curvature, which means for the given pressure, the wall stress will be the lowest in the apex by definition. And that makes that when you look morphologically at the tissue of the ventricle, what you see is that always the wall thickness in the apex is always the thinnest as compared to all the rest. And the reason why it can be the thinnest is because intrinsically wall stresses are lower because of the fact that this curvature is higher. And interventionalists and surgeons are happy because of this, of course, because your apex is the thinnest region. So when you need to enter the ventricle, and to enter it as safely as possible from the outside, is doing a puncture through the apex is the most safe because of this fact that it's the thinnest, and of course also your stresses there are the lowest. Now, if we go and look at the other regions of the heart, what you will see is that the lateral wall, of course, the free wall of the left ventricle is much flatter. So intrinsically, the wall stress is a lot higher, and that's also why a normal ventricle is thicker there. When we look at the septum, as I showed in that picture before, the septum is the flattest area, especially the mid-septum. So that means that wall stress is intrinsically the highest there. But also keep in mind, as we said before, is that of course, the stress at the septum is a balance of the pressure between the left and the right ventricle, because they act in a different direction. So that means that the wall thickness of the septum will be very similar to the wall thickness of the lateral wall. And so this geometry tells us something what the distribution of wall stresses will be, and actually how this geometry will actually change the wall stresses, but how this is compensated by the normal morphology. In such a way that in a normal heart with a normal pressure, you will see that the wall stresses again are equally the same everywhere, because that's the condition that the myocytes want to work. Now, if now something is happening in the periphery, if we have any change in the loading of the periphery, which has nothing to do with the tissue itself, now what happens is, of course, we have to see how the wall stresses are changing because of this. And what you can show is that if you increase the pressure, what you will see is that, of course, the increase in wall stress because of an increase in pressure will be related to the local radius of curvature. And what you will see here, and this is here in this plot is shown, what you will see is that the septum has actually a much bigger increase in the pressure when we have, in the wall stress, when we have a pressure increase as compared to the lateral wall. Is this more than just some kind of mechanical, physiological, interesting finding? No, this really has an impact on what you see in clinical practice and how the heart is remodeling. Because, for example, what you see here, and this is like a hypertensive heart, is what you see there is, of course, if you have hypertension, your pressure increases. That means that the wall stress in the septum, the mid-basal septum, is increasing more than somewhere else, which means that the threshold for a trigger for myocyte hypertrophy is, of course, reached first there. And we see that we get this like really localized basal septal hypertrophy in pressure loading. So we will see that it's very typical. So this is actually very sensitive for knowing that there's some pressure changes, because this will be the only reason why you would have a differential change in a trigger for hypertrophy. Yeah? So, and that's why we see that. Now, if we compare, for example, to hypertrophic cardiomyopathy, what you see sometimes in hypertrophic cardiomyopathy, you could see also this localized hypertrophy, but what you see that happens is mostly is that it's much more heterogeneous. So you see here in these HCMs, you see that it's not this kind of really localized where we have the highest radius of curvature, that's where we have the most hypertrophy. No, we see that it's in other regions also. And in HCM, and we come back to that later on, the hypertrophy is again triggered by an imbalance between the contractility and the loading. But now the reason for this imbalance is that your contractility becomes abnormal predominantly by fiber disarray or cellular disarray within HCM. Because in every individual with HCM, we will have regions where we have a total abnormal kind of organization of the myocytes within the matrix, making that locally the contractility goes down, making that obviously the wall stress or the balance between the pressure and the contractility will change, which means that you locally get a hypertrophy here, and that makes why you get hypertrophy. That's also why in HCM, you see a change over time. Children or very young children with HCM, they have less hypertrophy and less problems. The older you become, the more remodeling you got and the more problems you get, predominantly also because likely you have a change in blood pressure also over time. But what is important is that with, for example, as we said before, hypertrophy, but the same thing will be with mild aortic stenosis, for example, you will start to see this septal bulge, which means that this is a hypertrophic reaction to a change in loading, which is induced in this case by an increase in the pressure. Now, how is deformation changing? Well, what we said before is if you increase the loading in a certain segment, your deformation will go down, and that's what you see. So the local hypertrophy actually would try to compensate for this. So the more hypertrophy you have, the more contractility you have, and also you will locally change a little bit the geometry, so you can try to get the wall stress down. So you try to compensate, but what you will see is that this is rarely fully compensated when we look at the patient. And we see, for example, in this patient with hypertension and this local septal bulge, what you see there is that locally in the basal septum, what you see is that instead of very, very homogeneous deformation that you see normally over the septum, what you see now is that in this basal part, you first get stretching because of the fact that your contractility cannot compensate for the high wall stress, especially in the beginning of the cycle, as I said before, because the wall stress is always the highest in the beginning of the cycle. And then you see that later on, it can overcome a little bit, can have some systolic deformation, but predominantly, and that's because of the fact that there is less systolic deformation compared to neighboring segments, you start to get a whole bunch of post-systolic deformation. So through pressure loading, what you get is you get a local trigger for hypertrophy, which would be predominantly in the basal septum in a normal heart with a normal geometry. And additionally, on top of that, what you would have with loading is that you will have a change in systolic deformation, predominantly because the contractility cannot compensate the loading. And if you have this decreased systolic deformation compared to all segments, because this post-systolic, as we said before, really needs this differential deformation in different segments in order to be expressed. So when we have these conditions, you see post-systolic. So in the basal septum, post-systolic deformation, and especially a lot of post-systolic deformation, again, is very typical for pressure loading. In normal hearts, what we see is that because of the fact that even here, there's not much here, but what you will see is there's always still a little bit or potentially a little bit of decreased deformation in the basal septum, sometimes with post-systolic deformation, because of the fact of the geometry, that might not be fully compensated, and with alterations in pressure. For example, also regarding to this pressure-induced post-systolic deformation, what you will have is that this can actually change during the respiratory cycle. And because what happens is when you're breathing in and out, you change the pressure within your thorax, which means that you change the pressure in your right ventricle, which means that you change the balance between the right ventricular and the left ventricular pressure over the septum, which could be that when right ventricular pressure goes down and left ventricular pressure remains the same, you get a little bit of post-systolic deformation. So some people also show post-systolic deformation depending on when you're in the respiratory cycle. But so looking at the basal septum, or at least the region with the flattest kind of walls, that's the thing which is relevant when we look at pressure loading. Now, what we also have to keep in mind is, of course, that pressure loading or the wall stress is what the myocytes feel. So what is important is, of course, if we look at the bulk of the wall, then it's, of course, the flatness of the wall which plays a role. But if we look at individual myocytes, we have to look at how individual myocytes are oriented within the wall in a certain position. As we said before, is what you have is that you have this very specific architecture of the myocardium, where we know that in the epicardial wall, the cells are oriented more or less longitudinal, in an oblique way also, but predominantly from base towards the apex. In the mid of the myocardium, they're predominantly circumferential, and in the the endocardial region, they're again longitudinal. So when we look now at these fibers and how the wall stresses are changing, then of course, when we look at the endocardium has the flattest walls, and the myocytes are oriented in this direction. When we look at the myocytes in the mid-myocardium, they are oriented circumferentially. And of course, when you look at longitudinally versus circumferentially, the circumferential direction has a much smaller radius of curvature. So intrinsically, when we look at the wall stress in the circumferential direction, it will be lower than in the longitudinal direction. So that means also vice versa, when we have an increase in wall stress, what happens is that the longitudinally oriented cells are more influenced by this loading as compared to the circumferentials. So you would expect that with pressure loading, actually longitudinal oriented fibers or cells are actually suffering more than circumferential. And that's actually what you see also. And here is an example. Now it's shown with M mode as ring motion of aortic stenosis. And if we compare the longitudinal function with the radial function, what you will see is that in pressure loading, in this case aortic stenosis, what you will see is that your longitudinal displacement is really reduced, while normally it should be clearly over 1 centimeter in a normal heart. You see it's reduced here. You even see a little bit of post-systolic deformation here. But what you see is when you look in the radial direction, you see that it seems to be hypercontractile. So you see a shift of the longitudinal, which is more loaded or which is suffering more when you have a pressure load, towards the circumferential, which is actually more compensated. And so if you get hypertrophy, and then the hypertrophy makes that the circumferential direction can actually compensate in some ways for this longitudinal direction. So here you see another example where again, when we look at the longitudinal direction, you see that with bending, this goes down. in the longitudinal direction, while when we look in the radial direction, so when we look at the thickening, we see actually that especially in the beginning of this is aortic banding, so an increase in the pressure. In the beginning of pressure loading, the radial deformation will compensate for the circumferential, for the longitudinal. So the longitudinal goes down, and it's only at very, very high loading what you start to see is that actually both go down, and that's when the heart fails. Now, interestingly, also what you can see there is when we look at the kind of the rotation or the twisting, what we said before is that the rotation, the twisting of the base with regard to the apex is actually because of the obliqueness of the orientation of the myocytes within the wall. So the myocytes are oriented obliquely in the epicardial layer. So when they contract, they would do a rotation of the base towards the apex. In the endocardial layer, they're oblique in the other direction, and they would counteract, but still in a normal heart, epicardium is more dominant compared to endocardium, and the epicardium is making the rotation. Now, if we have pressure loading, what you will see is that, as we said before, it's the endocardial wall, which is because of its longitudinal and because it's actually closer towards the higher pressure, what you will see is that the endocardium is affected more by pressure loading compared to the epicardium. And so what happens is you lose some of your endocardial function. Your epicardium now, of course, remains the same, at least in the beginning, and the epicardium for the rotation becomes more dominant since we don't have any endocardial kind of counteraction anymore. And what you will see is that actually the rotation will increase with pressure load. So that's one of the reasons why kind of torsion is actually potentially not an easy way to look at abnormalities, because, for example, with pressure loading, you will see that it increases. With a lot of dysfunction, you will see that it decreases. So, but this is important to know because it's based on this geometry. And so what you will get there again is that this local shape and deformation can partially compensate for this. So what we said before is what you will get is that your local sphericity, again, when the septum becomes flatter, you decrease the wall stresses, and also you can make that the circumferential fibers can become more dominant, so you can keep your deformation and you can partially compensate for this. So what's always important is look at this combination of shape, local shape, deformation, and the local loading in order to understand what's going on. And so just also to illustrate this, that these regional changes are important, here's an example of the remodeling that you get or the damage that you get when you have, for example, pressure loading. So when you have, for example, long-standing aortic stenosis and severe aortic stenosis, what actually happens is that at some point, the myocytes cannot compensate anymore with hypertrophy, and you start to get myocyte damage. You get local cell death, you get necrosis, and you get fibrosis there locally. But when you look at this localization of fibrosis, then you clearly see that this follows the area where, because of the geometry, the wall stresses are the highest. So you clearly see that it happens at the base part, base inferior, base septal parts. That's where you first get the fibrosis. And then with severe fibrosis, you see that it becomes more towards the mid. And apical damage, so you never will have apical damage, apical fibrosis when you have pressure load. So if you would see a patient with, for example, late enhancement of fibrosis in the most apical regions, what you know is something else is going on. And just also to illustrate this, here's an example of tissue of, in this case, this is a congenital aortic stenosis. So this is actually from a neonate that died of heart failure because of congenital aortic stenosis. And when you now look at the tissue, and this is actually a piece of transmural tissue, you see that there's only fiber disarray and fibrosis and like a total matrix mess up because of this. So even if development takes place under abnormal loading conditions, you see that there's no way that we can get normal development. And of course, knowing this is something that you can never compensate and that you always will have to live with. Okay, I think it's enough for today. So the most important that I want to tell you is that, okay, loading will change the local wall stresses and what the myocytes feel, but this depends very, very much on the overall shape of the heart. Depending on where you are, depending on the local shape, you will see that the myocytes will feel this different. And also, of course, the fiber orientation is related to this. And because of this, you will have, depending on whether you have really acute or more chronic changes, you will see that you get regional differences in the deformation, where if there's no compensation either by shape change acutely or by hypertrophy locally, what you will get is that you get always decreased deformation, potentially with concomitant post-systolic deformation if there remain these differential changes. And so by looking at this, by interpreting all these things at the same time, contractile force development modulated by hypertrophy, the wall stress is modulated by local shape, and potential tissue changes, which is modulated by long-standing damage, then we can try to understand or infer from the deformation what's going on in these patients.